So when you have to always choose one of those things. So I think always the simpler is the better. Simpler is the better. So just my favorite technique is just three intercalated suture with bike glue. So even you don't have to take out the stitches. Just let the patient go. Oh, they're good, quite good result. But if you're very concerned about disappearing the sutures, the double line, you can use the buried suture with a nylon or and oh shit. So the other ways is that just single continuous sutures. Oops, videos. I will show the video later together. So the second one is Indonesia DCL. So many of doctors doing that, but so if you are the patient, you really want to scar it here, it will disappear. And so they think, some doctors still think that external DCL has better result than the Indonesia DCL. No way, I don't think so. It's almost an even better. And scarring and long operation time and pain. So it's disaster for the patient to stay physically, yeah, completely hiding the scars, but you can still see the scars. So most patients, if you do the Indonesia DCL, most patients and doctors will be very happy because simple and no visible scar. Operation time may be less than 10 minutes. Yeah, some patients, yeah, takes a little bit longer, but usually. So minimal pain and very fast recovery. So it's not coming either. Okay, this is the post-op state of so. And for the blepharoplasty low lead, they usually all the doctors, the past and still most of plastic surgeons prefer the subciliary incision. So they should be done to take out the skin. It's done by the subciliary incision. It's really, I don't think so. So for if doing that, even the patients, because they have many complications, you cannot see here, but ectopens and many complications happens by the plastic surgeons or the unskilled doctors. So we are the ophthalmologists. We are very familiar with conjunctiva, why we should go through the skin. So we can do it with no scar and just fat remover or just replace the fat through the hair. And if you have a skin redundance, just we call pinch technique. Just pinch and take out the skin and suture. This even done, but both eyes you can do in less than 1 hour. So saving times and saving the money and swelling is lesser and but 1 week later it looks very natural to the patient. So we can both use the both or whatever preceptor or postceptor, it doesn't actually matter, but so we'll no, okay. So even the invisible scar for the transit is that I think the better operation field transcutaneous for the octave fracture repair. Yeah, I don't think so. It's sideroid. So scarring has a problem. Cannot see here. What should I do? So we should go for transconjunctiva, or I introduced the first in the rule, the transcadental approach for the medial. And just because many doing the decompression, we go through the transcadental, but so why we cannot do this reconstruction? So I tried to go through the transcadental for repair the medial wall fracture, and some first case is the octave field is removed a little bit very narrow, but after you can use it is used popular in Korea and everywhere in the world now. So video I will show later. And even the deep orbital tumor, if the mass is big, patient prefer to the lateral orbitotomy. So and osteotomy, so it takes at least 2.5 hours to remove the tumor and close and cut the bone. So, and there's huge scars in here. So people think the big mess is always done by the lateral vitrectomy. No, I don't think so. So small is, it's not small actually, but anterior incision, which shows less scar and no osteotomy, but shorter operating time. But limitation is always, yes, there are limitations. So sometimes incomplete tumor removal is possible and can access the inferior part of, but so, but and we don't take out the suspicious malignant tumor with small incision. So you have to sure about diagnosis that the peripheral anatomy and should know the optical anatomy very well. And so I did several cases by this anterior technique. So like there's one, huge one, and scars and visible 1 month later. And we can do the posterior one too, and medial, and not even the small one. So, well, we have to fit the patient's needs. So invisible scar or less scar. And how can I be a good oculoplastic doctor? Yeah, I think always I'm talking to the doctors, but you have to think always what is the best benefit for the patients, what they want. You have to hear them. No, don't go your way. Just hear what they want, and you have to modify and create thinking, always thinking. So not just follow your teachers or textbooks. You have to always think about how can to reduce the scars or the benefits for the patient. And in the operating table, I'm always saying you should know where you are. So what are you doing? If you don't realize two things, you can avoid the complication, serious complication of the surgical excision. So this is case of Korean Society of Ophthalmology. It's short introduction. So about 230 team members, and like this year was me, handsome, right? So Photoshop. Okay, thank you. And Yoon Do Kim, former president. So this about months ago, we had a 30 years anniversary of the case of San Hunters there. So let's make the brief of, so will the Korean case of St. Kim's Hospital will support, and if anything is to question about the things, just email me, cyber.kim.com, and I will show you some videos. And can I open the files? Okay. No, it's not finished yet. The single continuous stress. No. The second one. The second one. Yeah, second one, single. Yeah. Oh, sure. I prepared about 4 or 5 videos, but is it working? Oh, come on. So this is a single continuous suture technique for the patients. So it takes about, from doing both sides, takes about only 15 minutes, and the result is quite good compared with so we can use it a little bit thick eyelid patients too, because we leave the sutures in the eyelid. Okay, and the second one. And the laser. Yeah, people prefer to take out the laser because I just burn out. So it's faster, and the bare bone I use the drill because it's faster. There's no other reason. And the Korean patient, the bone is thicker than the Western, so we should sometimes we can do, but without the drills. But usually we need drills, and the key thing is to take out the thick bones in upper there, and you have to always see the common canaliculus. This patient has no common canaliculus, and both two, just superior and inferior canal occlusion, just come through the lacrimal sac system. So take out the lens front of the lacrimal sac.
Xong rồi là bài của chị.
Em là cái bài filler đó, bệnh lý thần kinh hệ.
We'll see that two sides, right? It comes with two sides. So not always the patient has a common canal occlusion. Then the medial wall, yeah, no, this subrow, just show me subrow. So this is subrow technique, recently quite used in Korea, because if you use that, this patient's about 65 years old and quite of the drooping of her eyelids, and so what we do is just take out the skins and subcutaneous tissues, both sides, and suture, fixing the periosteum of the blow and fix it. So we show that the eyes lids coming up, and close. So it only takes about 20 minutes too. So always think about the surgical method. Okay. Stop. So thank you very much for listening.
Why do I want to